Dear Michael, dear friends, we will be sharing our ProCon lecture about if it's automation or POCT better. I will more focusing on automation, and Jan Watson will be a little bit supporter for POCT. The trends in the healthcare today, it's moving from inpatients and hospitals through outpatient departments, health centers, to treatment and home, and also on the other way for a specialized treatment. The laboratory medicine is very developed part of the medicine. If looking into modern hospital 100 years ago, we find microscope, centrifuge, Bunsen burner, colorimeter. That's enough. If you look into the labs in this year, it is an automated system from different companies, the wide portfolio of analytes from classical photometric analysis through immunochemistry tests and other which should be in the line. The automation, if we're looking, it is a process and it's looking for the increasing the productivity, also looking for the cost of the services, and it's looking how it's automated system. All people now at the beginning of the 21st century discussing about the robotics, about the Industry 4.0, moving the different scale, and automation maybe in the car industry, it's 96% is done by the automate. And also there is different lines which should be for more efficient labs, and we're looking also for our best services for the patient, for our colleagues in hospitals, in outpatient department, and there is a potential also improving. For the stakeholders and persons for the healthcare management, it's very pressing to the cost for whole healthcare portfolio, which is increasing due to the very precise therapy, new drugs, and also the new technologies. And but the laboratories it spend approximately 3 to 5% of the cost of the whole healthcare budget generally. But also there is a pressure to be effective and to be centralized and make some big private or regional or some states network. If you're looking for automation, we have 3 steps. First, no automation. It's mostly in the very small labs, in maybe areas which is quite far from the centers. Partial or modular automation, which is a trend at the end of the last century or beginning of this century, where is some automation islets with high throughput analyzers. It's not integrated to the one line. But if you are now discussing about the total laboratory automations, we put together on the one part analyzers from chemistry, hematology, immunochemistry, and in near future also the microbiology, connected with the automates for the pre-analytic and post-analytic phase or modules here. What if we're discussing the modular automation, we should be also looking for some advantages of the modular automation. It's maybe very rapid changes of these modules. It's easily reconfigurized. We should put the other ones or updated the systems, and it's a more easy also for the maintenance in the labs and fitting in the rooms. The total laboratory automation, as I mentioned, it is a phase from the specimen entrance up to the final results, storage of the samples, and there is also some steps as we have the last lecture by Julian Bard about and discussing how it's efficient, the reruns, if it's putting automated, or we go to the Ulysses syndrome for some for the results. It is a process of total laboratory automation. What are the advantages of the total laboratory automation? It's generally a lower cost of the laboratory diagnostics, reduction of the manual workforce, but we need a new position new type of the staff, which will be more experienced, and we also have the way for requalification of the staff. And it's, on the other hand, it's coming to reducing the personnel costs. It's maybe improve the quality, decrease of the risk of the errors, because the systems from the beginning to the end point is automated, monitored, and we have the data. It's tightly connected to the standardization of the process. It's maybe a little bit helpful for accreditation or certifications. And lowering the pre-analytical and post-analytical costs. It's maybe the decrease the number of the tubes, and finally also there is a very efficient space for storage. If you're discussing that we have a lower number of the tubes, it's some ethical aspects. We need also the lower number of or smaller sample of the blood. And it's, as I mentioned, the monitor systems. There are two systems which are made as the mirrors parameters, or some critical analytes maybe in the both analytical systems, and it's maybe improving the efficiency and reducing the TAT, which will be also important for the making decision in the healthcare process. But there is also the limitation of the total laboratory automations. It is an investment of the project. It is also the problems with the space. We need a large space and technologies. Totally different the maintenance. We need to change the mine. Reduction of the staff, it's also have some influence on the atmosphere on the labs. There is also the risk of the failure of the system in some critical points. One issue, it's dependence on the one key company which is leading the automated systems. It's clear that the one company is leading with additional of some other companies which is added systems, maybe as example, the diazorin is added in some lines or other ones. And we are in the potential risk. We have a very good idea. We have how to do this project, but we should also make mistakes and make not a good strategy and have some problems on the workforce. And also the IT and the system is a critical. I made one clear example because in automation in chemistry labs it have a long history, but the microbiology, it is a very new story, no older than 10 years. Now there is two systems which is totally automated. One is a Kiestra from BD and Vaslab from Koppen, which starting from the inoculation unit through the track system, incubation part, workstation, included the Malditov techniques, which is coming on the market 11 years ago, and it is maybe the revolution in the microbiology. And there are the systems, there is the pictures of the both one, the Koppen and the Kiestra. Now at the place of 45 system with some sorter, barcode, inoculator, digital imaging, which is work on different areas on the work. And it's go clearly to improving the efficiency, reducing the time for reporting, and it's also some automated culture interpretation by the working with the digital imaging and scanning. It is a clear example what's dramatically changed in microbiology during the last 10 years, and the microbiology in the future it should be connected in the lines which we have in some labs. If we have the core total laboratory automation labs, we have combining the equity and assets. We also be competitive in the now it's joining Europe and also compete with the small labs. There is also the sharing the financial risk for these long-term projects and coming to the more efficient and economic systems. There is maybe some symbolical parts to joining from the sample management through hematology, immunochemistry, urine, coagulation, chemistry, microbiology. We should edit maybe the 80 90% of analytes to one line. It's a reality now. Automation, as I mentioned, and robotics, it's in change in many areas. It's need also in the labs to reorganization of the labs, to requalified staff, make a central core lab with some peripheral labs in the hospital or in the outpatient departments. What is the one, I think, the education or scientifically area, it is broken the barriers between the disciplines, between the immunochemistry, coagulations, microbiology, and it's maybe the sharing and coming really to the laboratory medicine and the clinical chemist. It is we are the leading forces here. It is more efficient with a complete IT solution and educated staff. And as we discuss what about the laboratory service, I mentioned that it is not pro-contra if it's automated or POCT, but it must be the different scale. The central lab with some peripheral labs, which is also make some supervision on the POCT technology. Central lab, maybe in the university hospitals, is also govern the POCT system in the ward, intensive care unit, surgery, hemodialysis unit. And the POCT is also separated from this complex scheme from central peripheral labs. It's a GP's home, which many tests is done by the patients, pharmacists, and there is also separated some very focused and special labs. It's maybe how it's placed the laboratory services at the time, and I also think that it will be in the next decades on the same scheme. Depends how the central lab it's work, if it's also with a POCT or in the peripheral lab, but many complex laboratory providers in private, but also in the government or regional or huge hospital networks are working on this scheme. And we have some lights, also some dark parts, but at the end we will go and looking for the better services and safer services for patient and also for our staff. Thank you very much, and now it's Jan spoke about the POCT.
Good. So, disseminated laboratory support. So, Thomas has given a nice background to centralisation, automation, and where we are. And because around that, and we've been talking about this through this meeting, and we're all well aware of the need for quality. And this is Graham Beastall's take on the various aspects that we need to bear in mind when we're providing a service. But also looking at these other issues of, where are we? Is this actually, novel applications, cost effectiveness, education, clinical effectiveness. And that kind of takes you on a bit to the issues of how you provide a service. So, yes, consolidation is a reflection to increasing the workloads, and we have an ageing population, so we know there's more work coming through, and that is met by automation and the decreased costs that go with the automated services, and the standards that are achievable. In the background is the decreasing health budget and various government policies. Now, the consequence of consolidation can be that you're just a results factory, and some of the issues we were talking about in the previous session about adding value in one way or another may be lost. And certainly, I certainly go for the second option of a professionally directed service with links to universities and hospitals, which feeds into the added value to the laboratory service. And again, I mean, we can consolidate everything on one site, which a lot is often done for primary care services, and logistics there is key, and we're going to hear about a novel approach in the next presentation, which I'm really looking forward to. One of the massive issues which actually causes real problems is compatibility of IT, not just for the transmission of the laboratory results and the requests, but also integrating that into the electronic health record. A more common approach is, as Thomas showed in his slide, is a hub-and-spoke approach, where you're providing specialist services at the hub, and there's routine services at the various spokes, and then sub-spokes from there perhaps for POT, and again, POCT. Again, there's a key issue with IT and also comparability of results that are produced. Now, I mentioned government policies, and one of the things that governments are coming to realise that patients in hospital cost money. And so, ergo, you do not want patients in hospital if you can possibly avoid it. And you don't want them coming to outpatient clinics. What you want to do is provide them services in the community, which is absolutely great. It's easier for the patients and sounds like a reasonable approach. The issue with that, of course, is how do you deliver the investigations that are going to be necessary? And so if you're having a drop-in clinic where you're doing physiological measuring, so that's ECGs and blood pressure and what have you, and there will be some need for some laboratory testing of one kind or another, whether it's a monitoring or diagnosis. And the answer to that, of course, is point-of-care testing, which brings up a whole range of questions, which I intend going through. And I'm hoping, as this is a pro-con, that we actually then have a bit of a discussion about where we go from here. So, point-of-care testing in hospitals, very well established in various areas, and again, Thomas nicely illustrated that. To me, the point-of-care in the community is really one of the most important issues, but we also got a very good example in Hugo's presentation, the first thing yesterday, on how patients can actually have a very good point-of-care testing devices, the scan of the glucose on their shoulder. And that is great, but again, you hit this whole issue of IT compatibility. And we had talks yesterday evening talking about how you can feed data in and the compatibilities of that data, which I must confess, I still don't quite understand how those compatibilities are going to be achieved because you have different units, different methods and all the rest of it. But equally, if you're going to have a patient electronic health record, those point-of-care values probably should be in it. And that's perhaps a point of contention. Another issue is the personnel competencies to provide point-of-care testing because it needs to be standardised, it needs to be controlled, and it needs to be dealt with properly. And of course, the unit costs of point-of-care are high. So if a laboratory is providing point-of-care, it's expensive. But is it expensive in terms of the health economy? So, my point is, point-of-care testing is a laboratory. It's just a small laboratory. So it has all the expectations you have against the laboratory. And the first and most important thing is that if you're going to do point-of-care, it has to be a corporate agreement. It has to be in association with the management, and it has to involve the laboratory. So we have the ISO standards, and there will be maybe national regulations, and the stakeholders who are involved have to be engaged. And that's not just laboratory, it's not just management. Perhaps it could include patients, certainly general practitioners, etc., etc. So I just want to take different stakeholders' points of views just to raise some questions. So the first question is, do you actually need the point-of-care testing? Because quite often the question is, I want a result. And then the answer is, well, how quickly do you need that result? Can you do it by direct access to the lab? Because that's going to be cheaper. If you're doing point-of-care, there may be issues of fee for service. How do you get paid? It may actually provoke the laboratory to improve its logistics. Maybe getting some drones might be the ideal answer. The training and support required for the patients or the staff using point-of-care, who is going to do that? Is it going to be done to an adequate standard? How often are you going to do it? What's the additional costs of doing this in terms of maintaining the quality? And again, do I get paid? Patients now are expected to have access to the results without any question, and so therefore the point-of-care results must be in their record, and of course their laboratory results have been in their record. The patients aren't interested in the fact that we have different units, nor that we have different methods, but they want to be able to understand them. So I think Matthias's approach may very well be an answer to providing easily understandable interpretations for patients. There's this issue of informing the patient, which Julian has covered. I've talked about the overheads. There needs to be a clarification of the relationship between the patient's clinician and the GP and the point of care, because we're talking about disseminated services. You may very well be looking at cardiology patients for the cardiologist, but the cardiologist won't be there. And the same thing applies to the lab medicine stuff as well. And we've done a bit of work with our working group on patient-focused laboratory medicine in EFLM, showing that there is a limited role for specialists in laboratory medicine in interpreting results, not just to the requesting physician, but to the patients, and there's support from patients for that. Now, I said that the whole issue is the economics. And the funders' viewpoint is, well, is there going to be an extra cost? And because health economics to me is a bit like an onion. You peel away different layers. And if you look at the global health economy, the fact that I've got somebody who's not going to the hospital may make the cost of doing point-of-care testing worthwhile. And so can I save in that overall budget? There are issues about unnecessary testing, so guidelines need to be very, very tight. And as has been demonstrated again by Julian, there's no evidence of any impact on outcomes with point-of-care testing. Very, very little to show that it's worthwhile. There's one or two studies. I mean, there's an Australian study on GPs which shows some outcomes. Evidence of support, well, and again, this reimbursement thing. From an industry's point of view, point-of-care testing is wonderful because it's quite often a one-off use or a high consumable use product. The IVD industry is estimated in this year to be worth about $70 billion US, and about 25% of that is point-of-care testing, and that's growing as a percentage of that industry. So we're talking 17, 20 billion, so it's well worth doing. Growth rate of 10%, and the ideal platform from industry point of view is a high unit cost, used once only or have high consumable throughput. It gives the company direct access to clinicians, which means they can then sell them the idea of point of care, which is where the challenge comes for us guys, is saying, whoa, wait a minute, this is a corporate decision, guys, you can't go ahead and do this. And it's also where new markers are going. New markers are going direct to point-of-care platforms, not going to laboratory analyzers. And that captures monopoly, but also novelty, and is a great selling point and a great way of getting into the market. So this is, again, an issue. But we have to recognize that there are a lot of quality and reliable point-of-care devices out there that can be used, and as Farah mentioned, depending on what you're actually trying to do, you can use these quite reliably for the diagnostic purposes that you intend. So there's a positive opportunity there for health intervention. Again, it's a sales thing, and there is an opportunity to form a partnership with perhaps not just the clinicians but also the laboratory, and we talked before yesterday about managed service contracts, and this is the kind of thing where you can actually, if you're careful, you can build this kind of concept in to deliver services in a disseminated situation. The governmental viewpoint, because they may be the funder as well, is that you want to reduce the economic impact of ill health. That's what you want to do. And so prevention and early intervention are best. And again, this brings you to this community-based approach. And point of care may be seen as an effective tool. We don't think that there's any, I can't see why patients wouldn't accept this. The taxpayers may very well have something to say about the increased cost, but if you can prove there's a better outcome, and that's the difficulty, that they can't, then this may be the way forward. So macroeconomically, you think it's going to work, but you can't actually prove it until you've done it. So, point-of-care testing certainly enables disseminated a healthcare system, and is potentially empowering for the patients, although there's a lack of an evidence base. But the key element is that it must be operated in a structured framework, and that has to be linked to the core laboratory to maintain the quality standards that we would expect of a laboratory. And as a sort of subsidiary, and it extends the opportunities for specialists in laboratory medicine. In fact, there's some initiatives that are going on just now. There's a laboratory in France called, I've forgotten it, Lavelle, I think it is, who brought out a very good app for a mobile phone, which gives the patients all the information, what it means, links to interpretation, very, very, definitely the way forward and where we're going. So, I think there are some confounders, which I've mentioned. The IT compatibilities are always going to be a problem, and that needs to be addressed, and maybe some of the stuff that the big data guys are doing might be the way forward. Security is, of course, key. analytical harmonisation will probably never happen with point-of-care testing, but it's certainly a hope. And an overarching quality regime is imperative. Not just the quality regime you have in the laboratory, but the quality regime that you have at your point-of-care sites. So there's a lack of outcome data. There is an issue about the silo revenues. In other words, the silo revenue of my budget being higher because I'm spending on point-of-care and delivering a laboratory service you want, but you're not going to fund me. There are boundary issues between the different networks. So if I have one approach and you have a different approach and somebody's on the edge, just how does that work out? So there's a cross-border issue, not just within countries, but between countries. Patients may therefore choose where they go, which could cause problems. There's an issue about what the clinical needs are as opposed to what patients' desires might be, because you're going to drive an expectation by providing things locally, making it easily accessible. And there will be different imperatives between the central and local provision. So thank you very much for your attention, and I invite you to discuss it. Thank you.
Okay, so I think there's a number of questions, please.
Thank you. One issue you didn't raise was access, patient access. And in a place like Australia, we have two groups of patients who can't access routine pathology testing. One are people who live in the centre of Australia, particularly the Indigenous population, who have a high disease burden and they're not very health literate, and they tend to go somewhere, and if they get a blood test, you might not see them again for a long time. So if you can't diagnose and treat, even people with chronic disease, you just won't capture them. So they have a very poor health outcome. The other thing with the farmers in Australia, there's a story where I heard very recently where there was a medical registrar doing some rounds in an outback town. Patient came in with a very badly mangled hand, with a very badly mangled set of fingers, and they said, we'll have to refer you to a central hospital to have some microsurgery. And she said, just cut them off, I've got to go back to work. And then in large cities in Australia, we have a very high migrant population. About 40% of Australians are in fact migrants, and the first generation of migrants who come to Australia tend to live in the poorer parts of big cities. They tend to, after their children leave home, they've got poor literacy, poor language skills, poor transport, poor understanding of disease. Often they come from communities where, again, they've got a high health burden of chronic disease. And what we find in those areas, GPs spend a lot of their time contacting patients to say, don't come until you've had the blood test. Don't come until you've had the blood test. And still 20% of patients will turn up at the surgery, even people with chronic disease like diabetes, and not have had the blood test because they don't understand.
Is there a question that you want?
It's just a comment. I think you forgot about access. To me, access is the main issue.
Okay.
I think it's nice to comment the situation in Australia, and it's also this country is a little bit different in Europe, but thanks for it.
I think the thing that you're picking on is access to difficult to access populations. And I mean, there are discrete populations, as you described, like the Indigenous population. And it's well known that migrants are the people who suffer most in terms of healthcare, just because of literacy and their ability to communicate and all the rest of it. But that, and I think actually what's behind your question is the way that you organise your blood testing in relation to a referral to a primary care physician. For us, they would come to the primary care physician and then get the blood test. But I mean, that's it.
Okay, just a comment. You said that there was a lack of outcome research, and I think that maybe that was correct. And there is always a lack of outcome research, but actually there is quite a number of studies showing good outcome by using point-of-care instruments. So I have a list of publications, and I would just mention the last thing we did in Norway, where we looked at we are hosting a Norwegian diabetes registry with 60,000 diabetes patients, and we merged that, or we looked at that together with the external quality assurance program for hemoglobin A1C. And we could see that the general practitioners that had point of care hemoglobin A1C actually had better outcome for the diabetes patients. So that's some sort of evidence for the utility of point of care.
This is the issue. It's generally it's some sort of evidence. I mean, the Australian GP point of care, I can't remember who the authors were now, it was actually very good and looked at a whole range of analytes, but it actually came down to diabetes and I can't think what the other thing was. It was only a couple of...
but there are also, for example, for C-reactive protein, antibiotic prescription, PTH in the operating theatre, troponin in the ambulance, creatinine, as I mentioned, for monitoring kidney transplants, INR, point-of-care testing for patients.
But in the concept of a disseminated service, there's not an awful lot of information to say point of care. I mean, okay, the example you give, there's one. I mean, I'm not saying there's not any evidence. No. What I'm saying is there's not enough evidence.
No, but there is more than we think for a
large,
couple of analyses.
what you're going to have is a large investment in point of care expenditure.
But what's maybe the main problem you mentioned in Norway, you are connected the data. But there are the many data in the patient's home testing, which is not connected to GPs or some central database. So one issue, and sometimes what we have the problem and what we're doing 15 years ago in our hospital when we starting the network with glucometers, that we immediately take off 40% of glucometers from the wards because they are putting the very bad data. And it's a problem for the patient and quality of the services because patient looking, there is a number. If there is a number, it is a good number. Not discussing that maybe the cleaning, go to service, re-evaluate. It's maybe some problem for the patient and for the quality of the system. Yeah. To make the network and place a nice system that the patient should be in touch with the labs or through the GPs to re-evaluate the quality of these glucometers. As example, or for ENR testing, which is widely used in thrombotic patients. And also the second issue which should be placed, it depends how is the density of the labs in the country. Say it's very different maybe in Norway and Australia, comparing the Germany, Austria, Czech Republic, where we're looking from the window from one lab to other labs. Yeah, I'm joking, but sometimes it's true. To make a price of it. Yeah, it's if you measure the glucose or glycated hemoglobin in the labs and in the POCT, what the effectiveness if it's sending the sample or something. Yeah.
Okay.
Yeah. But I think the most important is that we have a quality system around it. So that's and that we as laboratory professionals have a defined responsibility into that quality system.
Okay, so we have time for one more question, please. Bernard, please.
Thank you, Jan.
Short question, short answer.
Okay, I have two questions.
Two questions.
So the first question, so you know that you were speaking about the management and the governance of point of care in the developed country. So I think that it will be also very interesting at the EFLM level to speak about point of care for the African countries. That means the low and middle income countries. This is important because it's very challenging. And if EFLM is not doing this, you know that today you have many IVD companies who are going directly to Africa. So we have to establish some links. This is my first question. The second point, you know that when you are discussing, you know that you are discussing of the traditional point of care. But if you are looking at the evolution of the nanotechnologies, you know, for the next decade, so you will get some, of course, improvement in the variable sensors. The second thing that you will get injectable and injectable sensors and also edible sensors. What is the role of the medical biologist in these situations?
This is really picking up on the conference we had in Mannheim of disruptive technologies and the impact on laboratory medicine. I mean, so Africa, yes. I mean, was it Julian mentioned that at the end of his slide? And then, I mean, there is an African association in IFCC, as you know, and I guess that's really their problem. But I guess the EFLM might be wishing to help them. I don't know. That's something EFLM needs to discuss. Nanotechnologies, well, yeah, they may be very good. We don't know how what's the traceability of the nanotechnologies? The answer is at the moment we don't have any. So I think that's perhaps a little way off, maybe something we need to think about, but I don't think we can answer.
Looking at the work of the Microbiology team or Stanford, as for example, and also Paul Saunier, you know that we can do everything with the implantable sensors. So it's a revolution.
But that's right. But it's actually monitoring trends and changes in specific instances. So we probably, to be honest, the truth is we don't have a role in that. Adam.
But I think what the mentioned Sverre, we should manage the system and also looking for the quality, because it will be the same. You have some nanochip or something in the body on the wireless technology. Somebody should manage it, and somebody looking for the quality and accuracy of these techniques. Yeah.
Okay, so
and it's maybe our duties. Yeah.
Okay, so that's very clear. Thank you very much.
You.